Hello, students. Today we're going to be going through Chapter 10, which is nursing care of the woman with complications after birth. So these are the categories that we see. We have shock, which usually comes from hemorrhage or infection. Women are at much higher risk of developing a clot afterwards, after delivery. So we have thromboembolic disorders, infections that I already mentioned. Subinvolution of the uterus. This is when the uterus does not clamp back down to the size that it needs to be, and mood disorders. We've already discussed or will discuss the normal postpartum, and these are the things that we see that can go wrong in the postpartum period with the woman. So our assessments in the postpartum period, they start immediately after the placenta has come out. And so for the first 2 hours, we are looking at our mom assessments every 15 minutes. We're also watching our baby very closely at this time as well. And then after the first 2 hours, we can move that down to every 4 hours for assessments. And we have to tell the woman, the mom, that we're not going to be in a room as often as we were during delivery, but of course we're always just a call light away, so that sometimes they feel like we've abandoned them. And then after 24 hours, it says here every hour, but that is actually a typo. After 24 hours, we are watching this woman every 4 hours until she leaves the hospital. So the assessments that we're doing is we're watching for temperature, we're watching pulse, we're respirations, blood pressure. We want it to be within normal range, and her pain goal. We'd like her to start getting that pain goal back under control. So temperature, there might be a slight elevation, but anything over 100.4 is considered a fever and needs to be investigated further. And then we're watching this pulse very closely because it's one of the signs that we have of postpartum hemorrhage. And so we do see a little bit of bradycardia right after delivery. And if the pulse starts climbing over 100, 110, we're starting to think that maybe there's some excessive blood loss. And then those respirations should go back down to normal, and the blood pressure should be within normal range. If she had high blood pressure before she delivered, she's going to continue to have high blood pressure for a little while. These are the fundal assessments that we've talked about. This is about where it is at the umbilicus, and we measure using our fingertips. If we put our fingers at the top of the uterus, we measure where it is in relationship to the umbilicus, or the U. It's either 2 fingers above, 1 finger above, 2 at the U, 2 fingers below, 1 finger below. That's how it's documented. So one of the things we're trying to prevent from happening is shock, and there are several different kinds of shock. Septic is obviously from infection that has gone unaccounted for, untreated. We have hypovolemic shock, which is too much blood loss. Anaphylactic shock is what would we see in relationship to a allergic reaction, or cardiogenic shock. And so the two that we see most often in OB are hypovolemic and septic. So one of the things that we do is we want to identify what a woman's risk factor is for bleeding when she comes in. So if she's low risk, these are the categories that put her in low risk, and this is what we're going to do. If she's medium risk, this is what would put her in that category, and these are the things we're going to do. And then if she's high risk, these are the things that we're going to do for her. And by utilizing this assessment, we're able to identify women that are at higher risk for bleeding and be more prepared and save their lives. It's one of those evidence-based practice events that have been put into place that have made a big difference in maternity care. So our hemorrhage, early is considered within the first 24 hours, late is between 24 hours and 6 weeks. They can continue to have a hemorrhage risk for up to 6 weeks. And the major problem with the risk, obviously, is they're going to lose too much blood. And signs and symptoms, first and foremost, is tachycardia. If we have tachycardia, we are on very high alert that this woman has had an excessive blood loss. By the time we get to a falling systolic blood pressure, we're really in a lot of trouble. We have missed a lot of our signs. pale, cold, clammy skin, starting to feel faint, starting to not be able to answer questions, feeling like she's going to pass out. And then decreased urinary output is one of those things that we see if we've had excessive blood loss. So we can measure things a couple of different ways. Estimated blood loss is looking at the size of the amount of the bleeding on the pad or the chucks or whatever it is, and then estimating what it is. But the evidence base says that we always estimate low. So we really, if she is moving into stage 1 hemorrhage, we need to start weighing those pads to know exactly what the blood loss is. So when we weigh a pad, we put a dry pad on the scale, we zero it out or tare it, T-A-R-E is what that looks like, and then we take that dry pad off, and then you put the blood-soaked pad on, and it will just give you the measurement of what the bleeding is. And so 1 ml equals 1 cc. So when we're weighing it, if it says that it's 50 cc's, that means it's 50 mLs. And so we're going to start keeping a running total of how much bleeding a woman has. This is what it looks like. These are the terms for the lochia, which is the bleeding after delivery. And this is how long they last. So in the beginning, we see rubra, that's normal, it's dark red, lasts a couple of days. Serosa is where it kind of starts to change into a pinkish brown. You can see that example here. And that's for about the next 5 days after she's gone home, usually. And then alba is that whitish yellow, and it can be up to a month. So this is a normal occurrence. It's not a period. It's the rest of the lining of the uterus that has been there to support the pregnancy. It's called lochia. So hypovolemic shock is when our blood volume is depleted and we're not getting our organs oxygenated. And if we do not correct it, the woman can die. She can literally lose her entire blood volume in just a few minutes. And in fact, it's one of the major causes of maternal mortality. If you look at this graph here, 35% of the people that die after childbirth die from hemorrhage. So more than a third. Hypertension, and that's usually undiagnosed hypertension or untreated. Indirect causes, things that didn't have to do with delivery. Abortion is another reason that women die, and sepsis. So you can see these are the things that we are working on, trying to improve our maternal outcomes. So I've mentioned this before, but AWON, which is Association of Women's Health and Neonatal Nurses, they are the organization that does a lot of research to try to enact some of these policies that's going to help change women's lives and nurses' lives, because if we are more aware of these things, we can practice these things in drills, then we can help take care of these women better. And so this is really where this postpartum hemorrhage project came from, and a lot of the practices that we now keep in place are because of this protocol. So QBL, quantification of blood loss, actually weighing it, is one of the things that has really changed how we treat postpartum hemorrhage. And then here's another picture, and you can stop the video and look at it for a minute. But what it is in our stages, and I've showed some of this to you because it sits on top of our hemorrhage cart, but it tells you what our roles are and what we're actually supposed to do in each stage. So then there's no question, everyone's getting the same standard of care. All the doctors are following the same policies instead of just making things up as they go. And this has really made a difference in being able to save women's lives. So initially, like I said, you're going to see increased heart rate, and along with that comes increased respiratory rate. Our blood pressure, again, is going to fall. That's a late sign. And we're going to see that pale, cold, clammy skin. You just kind of feel like you can see the blood drain out of their faces when they're hemorrhaging. Of course, you're busy doing other things. You're not sitting there watching that. The next picture is a drill. It's not actual. So this is the kind of thing that we use to teach nurses to estimate appropriately. So you can see that this picture here is showing that this peri-pad is completely soaked and it's giving you the amount of blood flow that is. If we start filling up a kidney dish, that's 500 mLs. If it starts spilling onto the bed, that's 1,000 mLs. If we are spilling off onto the floor, that's 2,000 mLs. So we know very quickly what stage of hemorrhage we're in based on just the look of it. And then, of course, we're going to pick all of this up and weigh it so that we can get a very accurate picture. So we want to stop the blood loss. What's going on? Why is she bleeding? We're going to be giving IV fluid. We might be using our rapid infuser. I have a picture of that coming up. We're going to be giving her blood products back, and we don't just give packed red blood cells. We do what's called the maternal pack, and it has packed red blood cells, fresh frozen plasma, and either cryoprecipitate or some other products I already mentioned platelets, to put all the parts back into the blood and not just give her the blood volume. We're going to be giving oxygen by 10 liters to make sure that we hyperoxygenate her so that we reduce the risk of not having enough oxygen to the organs. And then we're going to be putting in a Foley catheter that has a urometer, because we're going to have to watch her urine output very, very closely. After they've hemorrhaged, they have a high risk of kidney failure. And so we are going to keep a very close eye on that. So nursing care is going to be frequent vital signs. We were already doing vital signs every 15 minutes, but in a hemorrhage, we're hitting that blood pressure about every 3 to 4 minutes during the crisis. O2 sat is going to be continuous. We're going to be watching that lochia. Is there clots coming out? Are we worried that there's placental fragments that are still inside? Is it uterine atony, with the uterus not being able to clamp down and retract and seal off that place that the placenta was on? What is the reason for the bleeding? Sometimes it's a cervical laceration. If women start pushing before they're 10 centimeters, we have a chance of a cervical laceration. Sometimes there's a hematoma, which is a broken blood vessel underneath the skin that's bleeding into the skin, and mom is losing her blood flow there. So we have to figure out what the problem is. And this is when we have a physician at the bedside and we're trying to troubleshoot to see why she's bleeding, and also trying to stop that process. So the medications that we used, we've talked about these quite a bit. Our first line medication is Pitocin. We will bolus Pitocin in at this point because the baby's no longer inside. And so we will use that to try to help clamp down the uterus if that's what's going on. We can use Methergin, which is a vasoconstrictor. Again, we never use Methergin with a hypertensive patient. Don't even have it in the room, so we don't mistakenly give it to her. We can use Cytotec. Those are the little tablets that are going to go into the rectum, and that's going to also help to clamp down that uterus. And then we can use Hemabate. These are the only 4 medications that we have to use. And if we've gone through all 4 and she's still bleeding, we're going to have to think of other ideas to get her to stop bleeding, and we start going through the medications again. This is a picture of the rapid infuser that I was talking about. I've showed a couple of you in clinic what this looks like. This is really a 2-nurse operation. You're hanging blood and hanging fluid, and it goes through this little system that warms it up, because we don't want to put a lot of cold fluid into her body at this point. It's going to cause her to shiver, and she's going to use up more energy. So we warm the fluid in the blood, and these are pressurized and can allow these products to go in about 5 minutes. A liter bag can go in about 5 minutes. A bag of blood can go in about 2 or 3 minutes. So we're utilizing this sort of machine. If she's just pouring the blood out, we've got to put something back in, or she is going to die. These are some of the other tools that can be used. So this is a procedure that a physician would do. It's called a bimanual compression. And you can see the fist is inside the vagina, pushing at the same time on the outside, that they're pushing and putting pressure on this uterus to try to keep it firm. And this is an effort to save that woman's life. So it's not comfortable, but at this point, she will let us do anything that we need to do. If this bladder is full, that can keep this uterus from clamping down. So that's one of the first things we do, is make sure the bladder's not full, either by putting a straight cath in, or by having the woman urinate on a bedpan if we can, because we don't want that bladder to be full so that the uterus can't clamp down. This is a picture of a Backrey balloon. I'm going to show you one in class when we talk about it. And basically, it's like a giant Foley. A doctor places it into the uterus, and it does what this is doing over about 24 hours. So 500 mLs of fluid fills up, and hopefully it puts enough pressure against that uterus that it will stop the bleeding. And then last ditch effort, if we're unable to get the bleeding to stop, we're going to have to go back to the operating room, and the physician's going to do a surgery where they put a couple of stitches into the uterus to actually clamp down the blood flow. And then the very last ditch effort, they don't like to do this one because it's also a major surgery which involves bleeding, is they will take the uterus out. They will do an emergency hysterectomy in an effort to save the woman. So because a postpartum woman, they have a slow pulse after delivery. If it's over 100, you're going to suspect that she has had a bleeding or infection, excessive bleeding or infection. So this is why we're watching those signs so closely. Anemia may happen if she's had a hemorrhage, and that's going to take several weeks to resolve. After the crisis is over, if she has had a hemorrhage, we're going to be on the very close watch. She's going to have help getting up to the bathroom. She may complain of being dizzy, lightheaded. She may pass out. So we're going to have to talk to her about her diet, as well as maybe taking some extra iron to help support her as she's recovering from this major blood loss. So before, I mentioned early postpartum is within the first 24 hours. It's usually caused from uterine atony. That's the uterus not being able to clamp down. There's a laceration or a tear, or possibly a hematoma, like I've already mentioned. So this is when a uterine atony is caused by overdistension. So if you've had a really large baby, sometimes the uterus can't clamp down enough to seal off the bleeding sites. Sometimes there's retained placental fragments. A really long labor, you're at high risk for uterine atony. Or if we used a lot of those medications like Pitocin or Cytotec during the labor to help get the uterus to contract, those receptor sites in the uterus may be full. And so after she delivers, the uterus doesn't respond like it normally does. So actually that's a high risk for hemorrhage if you have a long labor, especially with the use of tocolytics. So the characteristic of uterine atony is when we're doing that exam, doing that fundal exam, the uterus is boggy, soft. The fundal height, it's up above that umbilicus, above the U. We're having large amounts of clots. There may be a large amount of blood when she stands up to go to the bathroom. It may just pour out because it's kind of been pooling in the vagina. And if we aren't doing that fundal assessment on a regular basis, the uterus can fill up with clots, and then we can have a hemorrhage on our hands. So it's very important that those fundal massages get done. The laceration can be on the perineum, up on the top or in the back of the vagina, on the cervix, or even around the urethra. And these can cause bleeding because there are vessels that have been cut or broken, and that will, it's very vascular down there, and so they can bleed pretty heavily. That blood is usually bright red as opposed to the clotted blood that's in the uterus. You kind of can see the difference when you've got a tear somewhere. The uterus will stay firm because that's not the problem, and we have to find out what's going on, where that laceration is, and the physician will have to come in and suture that to get the bleeding to stop. Hematoma, like I already mentioned, is a collection of blood within the tissue. That's where a blood vessel has broken within the tissue. It usually looks like a mass that's growing under the skin, and a woman will tell you it's extremely painful. They will start really talking about how much pain they're having down below, and you will see what looks like bruising underneath the skin or a bulge start to happen underneath the skin. And so we will have to go in and fix that surgically. The physician will take her back to the operating room and open that up and find whatever's bleeding and stop that in order to fix this hematoma. So a late postpartum hemorrhage is usually after that first 24 hours, and the most common cause is retention of placental fragments or subinvolution. Something's keeping that uterus from clamping back down and going back to normal size. So we have to teach the woman what signs of postpartum hemorrhage are and let her know when she needs to seek help. So soaking more than a pad an hour, bright red blood running down your leg, changes in the bleeding after it started to taper off, suddenly it becomes a lot more. We have to give her this information so she knows to seek help. And then some of the reasons that we have subinvolution of the uterus is, again, that fundal height was greater than expected. And it is because it was much larger baby, maybe multiples, or there's something in the uterus, placental fragments or something left, maybe membrane or tissue that needs to come out so the uterus can go back down to normal size, because those fragments continue to produce hormones and the body still thinks that the woman is pregnant. So again, we want to teach a woman really good aftercare instructions, things that she would want to report. Any foul smell coming from the vagina, any temperature, 100.4 or more needs to be reported. That persistent bleeding that isn't moving through the stages of becoming, going from bright red to brown to a very light color, and then tapering off. If that's not happening, she needs to go back and see her physician. And here's another picture. I brought that picture up a little bit closer so that you're able to see how this should happen. About day 8, really we should be back down into the pelvis, and it should be difficult to feel. And here you can see this woman is putting pressure, holding the uterus down below while measuring where that fundus is. The woman is also at very high risk for blood clots right after delivery. It's supposed to be that way so that she can clot down and not bleed too much. But we have to be concerned if she has things like already has a history of blood clots, if she has a blood clotting disorder, if she has veins in her legs that have become very prominent, varicose veins during the pregnancy. These are all high risk. If she's been in HELP syndrome, we talked about that in the last module. These are all very high risk for clots, and so we want to let her know if she's having pain in her calf, if she's feeling short of breath, she needs to call emergency help right away, because she is at much higher risk for the next 6 weeks. So the things that we want to watch out for: if she suddenly starts coughing, has a lot of chest pain, has a lot of shortness of breath, teach them not to cross their legs. That impedes blood flow, especially putting one leg over the other, like we're taught to do as ladies. That puts pressure on the space behind the knee, and that can encourage a clot. And if she is at really high risk, especially if she has varicose veins, we want to see her in SCDs while she's in the hospital. ICDs, SCDs, they're the same thing. Different hospitals call them different things. Or even some compression socks. And I'm just going to say here that you as nurses should be wearing compression socks, because you're at high risk for a clot for all the standing that we do. And here's a picture of the different types of things that we can use in the hospital. So if she ends up on anticoagulant therapy, it's just like anyone else on anticoagulant therapy. We have to teach her to use a soft bristled toothbrush, to watch when she's shaving, to make sure that she's not getting bumped and bruised, because she has a high risk of forming bruising and bleeding underneath the skin. And now we come to infection. Infection is anyone with a fever over 100.4 or 38 degrees Celsius after the first 24 hours. And this says up to the next 10 days. We say within the first 30 days after delivery, if you develop a fever, you need to contact your doctor and find out why. The most common ways for infection to happen are healthcare providers not washing their hands. So especially with all of the invasive procedures we're doing, Foley catheters, vaginal exams, the stitching up if she's had any stitches down below, those put her at very high risk for infection. And so she needs to, again, be looking for flu-like symptoms, extreme pain that she didn't have before, a foul smell, a fever. These are all things that we tell her the first time we get her up to the bathroom, because she's really willing to listen to you at that point. If she's had a surgical incision, she's at high risk for infection because of that. Even cracks in the nipples are from breastfeeding, if she hasn't been latching the baby on well, could have cause a problem. And we want to make sure that she goes to her OBGYN to help fix these things. Because if she goes to a regular urgent care or hospital, well, hospital ER probably would know pretty well, but sometimes the urgent care doesn't realize what the risks are right after delivery. So we just want to be mindful of that and give the mom good information. So the infection, if it is actually in her perineum or the vagina or the cervix, it can spread up into her uterus, fallopian tubes. It can get into the peritoneum, cause peritonitis, which can be life-threatening. So uterine infection or an infection following childbirth is severe. This is the #1 reason that women used to die from childbirth. And it was because of lack of proper hand washing. So I cannot stress enough. Yes, the alcohol is nice. It's nice to gel in and gel out. But once you get in the room, it's also appropriate to actually wash your hands before you touch this woman. And use gloves when we're contacting any body fluid, any place that could potentially have an open wound. Even when we're working with her with breastfeeding, we should be using gloves because we don't want to spread any bacteria to the breast if she does have any cracks there. So again, these are all the things that we just talked about that moms needs to know. The other thing is sometimes women don't understand about cleaning front to back. Wiping front to back is very important when you're pregnant. And then once you've had your baby, using your peri bottle and squirting front to back is very important, making sure we don't bring the bacteria from the back up this direction. And also changing her pad every time that she goes to the restroom, keeping it nice and clean, very important. No, they don't recommend any bathing in a bathtub for if there's been a cut or an episiotomy, unless that bathtub has been cleaned by someone else. Someone else needs to get in there and do it for them. And if they've had a C-section, they do not want them immersing that incision in a bathtub. So mastitis, another difficulty that can happen after delivery, is an infection of the breast. And it can either be in a breastfeeding woman or not in a breastfeeding woman. The signs of mastitis, and I have some pictures coming up, are extreme flu-like symptoms, fever, and then usually one area of the breast has a very hot, red, tender area to it, usually a circular area. Sometimes there is drainage, sometimes there's not, but if she has symptoms, she needs to be seen because antibiotics is the treatment. And a lot of places, if she goes to be treated, they'll tell her you absolutely have to pump and dump your milk, but you don't. And if we don't keep getting the milk out of the breast, she has a higher risk of developing an abscess. So it's very important that she continue to take the milk out of the breast. If she decides to feed it to her baby or not, that's up to her, but it's the tissue that's infected, not the milk or the milk ducts. So here's what I'm talking about. This is a sign. This is a mastitis. And most often this gets in because of cracks in the nipple. Bacteria gets in and it travels up into the breast tissue. So it's very, very important to continue draining the breast. If it's too painful to put the baby on the breast or you don't want the baby up there, then they need to use a hand expression or a pump to get the milk out of the breast. You want to treat the pain and swelling by using ice packs and hot packs. You can use painkillers, either Tylenol or ibuprofen will help with that, or the doctor might prescribe something else. You definitely need bed rest. And if you don't feel, well, this says if you don't feel better after 24 hours, but we say you need to go and get those antibiotics right away. So the other thing that we can do is encourage fluid intake. We want them to wear a supportive bra. This says pump and discard the milk from the affected breast. That's actually not current information. But like I said, a lot of women have a hard time feeding the milk that's coming from the breast to their baby. So that's okay. If you want to throw that milk away, you still have to keep getting it out of the breast. That's the most important. And so now we're moving on to mood disorders. And mood disorders are significant after postpartum. There is we've been talking about this for 20 years, and it feels like we're finally doing something to help women with this. We are now doing what's called an Edinburgh scale with every woman before she leaves the hospital to try to pick out some of the women that may experience mood disorders. So normal symptoms after you have a baby is feeling kind of overwhelmed, feeling like you are extremely exhausted, feeling like you're wondering if you're really good at this, being very tearful. And that can go on for a couple of, maybe a week or two. And that's normal. And that's because you're exhausted. You just ran a marathon. You do hurt. You do have this new little human that's up every 2 to 3 hours needing your attention. And you feel this huge responsibility. That's what we call normal postpartum baby blues. And that is very common. And that is not what we're discussing when we're talking about mood disorders. So this is usually self-limiting. And as the woman starts to adjust to her new role, she starts to find pleasure in her role. What we're talking about is as we move into a couple of weeks after delivery, 4 to 6 weeks, you should really start to feel like yourself. But this is, if we have postpartum depression, which is just a chemical imbalance, and it starts to interfere with the mother's ability to respond to her baby. It starts to interfere with bonding. And so if we start seeing signs and symptoms of postpartum depression, we need to contact the physician. So some risk factors for postpartum depression are if they've been depressed before, if they have a history of anxiety, if they don't have a good social support, if they have a lot of life or childcare stress, low self-esteem, maybe they didn't plan this pregnancy, maybe they're not in the relationship with their partner anymore. So these all put a woman at risk for postpartum depression. And here's some signs of it. Lack of enjoyment in life, not feeling interested in the things they were interested in before, just the inability to cope, feeling like they're not good at this, inability to make decisions, either eating too much or not eating enough, sleeping too much or not sleeping enough. So these are all signs and symptoms, and they need to contact their OBGYN because they're very good at picking out postpartum depression and helping treat it. There is treatment. It does get better. They usually put women on some medication to help them get through this period. And there's lots of support groups in town that can help as well. So one of the things that we can do is be a sympathetic listener. If you're working in an after clinic where you're seeing women that are coming in with postpartum depression, we want to help them. So as I was saying, with our mom that has postpartum depression, if she's starting to show signs, we want to make sure that we let her know that this doesn't mean she's a bad mom. This is a chemical imbalance. We can help her with it. We want to refer her to a support group. We want to make sure that her family understands what's going on. Let her make sure that she knows that she has support. We don't want her to feel alone, because if we let this go, if there's a shame in talking about this and we do not address this with this mother, then it could move on into postpartum psychosis. So this is the Edinburgh scale that I was talking about. This is one of the postnatal depression scales that we use after delivery. And if they answer, it's per policy, but if they answer anything over a 10, we need immediate intervention. And if they answer question 10, I have thought of harming myself has occurred to me, then we need to contact social services and get them involved and see what we need to do to help this woman. And then if we do move into postpartum psychosis, some risk factors for that are bipolar disorders or schizophrenia. We definitely can see some bleeding of these things. And this is when they start having delusional ideas about hurting their babies, hurting themselves. It can be fatal for mom or baby if it isn't caught and intervened. And there were a lot of really high profile cases over the last 20 years about women that have moved into postpartum psychosis. And the fact of the matter is, every single one of those people that had this issue, there were dozens of people around them that saw some of these signs. and didn't intervene. And so this is the big take-home message here, is that we want to make sure that we are intervening if we think these things are going on. So there's a possibility of suicide or infanticide. We want to get them to a counseling, get the baby to a safe place where they can be watched. And then the antipsychotic medications pass through the breast milk, and so breastfeeding may be contraindicated at this point. And at this point, it becomes the mother's health versus the baby being able to get breast milk. So we are going to support her in that decision, but then afterwards, sometimes there's some guilt involved in that as well. So that is our postpartum complications. If you have any questions, you know where to reach me.